We looked at estimating creatinine clearance using the Cockcroft-Gault equation. Now, the next learning objective is explain the mechanism of action and toxicodynamic properties of aminoglycosides. Most aminoglycosides are natural products that naturally exist in nature, and the naming of these aminoglycosides are actually based on the organism that they are derived from. So streptomycin, neomycin, and tobramycin are actually derived from Streptomyces species. We also have gentamicin, which is derived from Macromonospora species. We also have a couple of aminoglycosides, amikacin and polysomycin, that are semi-synthetic derivatives. So these are actually developed in the lab. Aminoglycosides are available as IV formulation, with the exception of neomycin, which is available as PO, and there is also a cream formulation. Aminoglycosides have concentration-dependent rapid bactericidal activity against gram-negative organisms. They inhibit protein synthesis by primarily binding to the 30S subunit of the ribosome. In this picture, we're looking at a typical bacterial cell. You can see that inside the cell there is a circular chromosome along with multiple plasmids. There are also multiple ribosomes. In prokaryotes, we have 70S ribosomes. So all of these 70S ribosomes are floating inside the cytoplasm. Now, the 70S ribosome is the primary site of action of aminoglycosides. The 70S ribosome consists of a 50S subunit along with a 30S subunit. Aminoglycosides in particular bind to the 30S subunit. The function of the ribosome is to translate messenger RNA into a polypeptide. So these amino acids will come into the ribosome and, based on the genetic code, form a polypeptide chain. An aminoglycoside will interrupt this translation process. Now, note that ribosomes are inside the cell, and in order for aminoglycoside to work, they actually need to go inside the cell first and then find this ribosome and inhibit protein synthesis. In this picture, we're looking at the cell wall of gram-positive and gram-negative bacteria. The primary difference between gram-positive and gram-negative organisms is the outer membrane that exists in gram-negative organisms. So there are two layers in gram-negative cell wall. There is the plasma membrane, followed by a tiny layer of peptidoglycan, and then the outer membrane. Gram-positive organisms, on the other hand, they have the plasma membrane followed by a thick layer of peptidoglycans, and there is no outer membrane. And because there is no outer membrane, this peptidoglycan layer can actually grow and get thicker. The reason this is significant is because aminoglycosides are polar and they cannot penetrate through the peptidoglycan layer. In order for them to get inside the cell down here, they actually need to use either porine channels or use carrier proteins. In other words, aminoglycosides cannot simply penetrate through these layers. Therefore, aminoglycosides are active primarily against gram-negative organisms because they can go through these porine channels, and there is a tiny layer of peptidoglycan that they can go through, and then they can go through more porins and get inside the cell where the ribosomes are. When it comes to gram-positives, because aminoglycoside cannot get through peptidoglycan, they do not have activity against gram-positive organisms on their own. However, we can use aminoglycoside for synergy with other antibiotics, and those other antibiotics typically are active against peptidoglycan layers. So if the other antibiotic will break down this peptidoglycan layer, then and only then aminoglycoside can get inside the cell and act on ribosomes and give synergistic effect with the other antibiotic. Now, when we look in more details of what happens when aminoglycosides bind to the 30S subunit of the ribosome, you can see that the first thing is that they block initiation of protein synthesis. And if protein synthesis has already initiated, they can block further translation and actually cause premature termination of translation. They can also cause incorporation of incorrect amino acids into the protein product. Now, when it comes to the spectrum of activity of aminoglycosides, and this is in general for all aminoglycosides, for gram-positives, it is essentially synergistic activity. So especially for enterococci, for some infections such as endocarditis, they are used for synergistic activity with other antibiotics, specifically with beta-lactams. The same for Staphylococcus aureus. But their true activity is really in gram-negative arena. So H for Haemophilus influenzae, so they have great activity for protease, E. coli, and Klebsiella, and of course for Capes organisms, and that's in general. So Citrobacter, Acinetobacter, Providentia, Enterobacter, Serratia. Now some of these can develop resistance, for example Acinetobacter, but there's a good chance that aminoglycosides will be active against these organisms. Now with Pseudomonas, I have put a plus minus because really the anti-pseudomonal aminoglycosides is tobramycin and plazomycin, and I'll talk more details about the anti-pseudomonal activity of aminoglycosides shortly. And they do not have activity against any anaerobes or atypical bacteria. Now in 2023, CLSI breakpoints updated. So prior to 2023, in up to 2022, there were breakpoints for susceptible, intermediate, and resistant for Enterobacterialis and Pseudomonas. What happens in 2023 was that because these breakpoints were pretty old, so they've been around since 1980s, and they hadn't been really updated, and we know much more about pharmacokinetics and pharmacodynamics of these agents nowadays. So the committee updated. So what they did is that they actually lowered the breakpoints for Enterobacterialis. So previously an MIC of 4 or less was considered susceptible for gentamicin and tobramycin. That has been lowered to less than or equal to 2. And this is assuming, the most common dosing nowadays is 7 milligram per kilo once a day. And this regimen is really designed to get an MIC of around 2, or I should say concentration of around 2. So an MIC of 2 or less was decided, based on many factors, including the dosing we use and the pharmacokinetics and pharmacodynamics, as well as clinical studies that are out there. Now for amikacin, the susceptible breakpoint was less than or equal to 16, and it is now less than or equal to 4, and that's based on 15 milligram per kilo once a day. Plazomycin, which is the newest aminoglycoside, came to the market in 2018. Previously, we did not have CLSI breakpoints for them. So now there are added, so less than or equal to 2 is considered susceptible for plazomycin. And this is for all types of infections. Now, with regards to Pseudomonas aeruginosa, previously, we had susceptibility breakpoints for gentamicin, tobramycin, and amikacin. What happened in 2023 is that gentamicin, given the distribution of MICs among Pseudomonas isolates and the PK/PD of gentamicin, it is no longer considered active against Pseudomonas. So in fact, there are no criteria for susceptibility for gentamicin in regards to Pseudomonas. So it was actually removed. In other words, if there is a sample sent to the micro lab, they should not be testing it against gentamicin. So you should just consider that resistant. They will not be testing to report it as either susceptible, intermediate, or resistant, because it will just not be susceptible. So we should just consider resistant. For tobramycin, the breakpoint was reduced from less than or equal to 4 to less than or equal to 1, and that is based on the dose that we can use safely in patients, because if we increase the dose, we can cause unnecessary toxicity. And with amikacin, it has remained the same. The only thing that has changed is that this is only good if you are using it for a urinary tract infection. So if you have Pseudomonas in the urine, we're going to get, using 15 milligram per kilo once a day dosing, we're going to get enough concentrations in the urine, but not anywhere else in the body. So for any systemic infection, amikacin is no longer considered active against Pseudomonas. And with plazomycin, which is again the newest agent, we didn't have susceptibility breakpoints before, and we still don't. So for Pseudomonas, we still don't have criteria for plazomycin. So let's take a look at the toxicodynamic properties of aminoglycosides. So of course, they do bind to 30S subunit and cause protein synthesis, and they are bactericidal. When it comes to adverse effects, the most common adverse effects of aminoglycosides are nephrotoxicity, which can be reversible, if it's caught early, but the longer and the longer we use aminoglycoside and the higher the dose, the higher the nephrotoxicity. So, of course, if you cause too much nephrotoxicity, there will be a point where it's not reversible. But in general, as, we notice patients will have nephrotoxicity, we can mitigate the toxicity and it can be reversible. That's not the same with autotoxicity, which is considered irreversible. So that's something that's, pretty significant. And there's also neuromuscular blockade. Now with nephrotoxicity, which does occur in about 10 to 25% of patients, neomycin is considered the most nephrotoxic, whereas amikacin, gentamicin, and topra are considered to have equivalent nephrotoxicity, with streptomycin have the least amount of nephrotoxicity. Now, nephrotoxicity is considered to be dose-related, and risk factors include increasing age, pre-existing renal disease, use of diuretics, exposure to radiographic contrast, circulating volume depletion, and use of other nephrotoxic agents such as ACE inhibitors, NSAIDs, amphotericin, or cisplatin. With autotoxicity, we can in general divide it into vestibulotoxicity and cochleotoxicity. So when it comes to the vestibular toxicity, streptomycin causes the most toxicity, whereas gentamicin and tobramycin cause about the same. And probably amikacin does not cause much vestibular toxicity. And vestibular toxicity essentially leads to dizziness, ataxia, and nystagmus, whereas cochlear toxicity is more serious. It can lead to hearing loss and tinnitus, or tinnitus, as some people would say, which essentially can be there for life because they can be irreversible. And with this, pretty much amikacin, neomycin, and tobramycin considered to cause the same amount. Whereas gentamicin is not really known to cause cochlear toxicity. With neuromuscular blockade, again, neomycin, kanamycin cause more, which is essentially why we don't use them for systemic infections. Amikacin, gentamicin, and tobramycin, these all can cause neuromuscular blockade, but this is not really common. So this is not common, and most episodes have occurred in association with anesthesia or the administration of neuromuscular blocking agents, and it can be reversible. And lastly, there are situations where we use a single dose of aminoglycosides, and it's good to know how safe a single dose is. So for example, sometimes we can use a single dose to treat gonorrhea. We can use a single dose to treat cystitis due to resistant organisms, and for prophylaxis prior to surgery or invasive procedures. And a systematic review of 36 studies, which included 11 randomized controlled trials, showed that a single dose of gentamicin, it can have an effect on renal function, but it's really considered mild and transient. So it's really not considered nephrotoxic in the sense that it will damage the kidneys. And there were no cases of autotoxicity associated with just a single dose of aminoglycoside. So, just a single dose is pretty safe. And, especially when we're waiting for susceptibility results to come back, it is okay to use aminoglycosides empirically, but we should streamline and switch to better options as soon as possible.